Now we are going to discuss surgery questions of AIIMS June 2020. So see the first question. A patient presented with breast lump. Okay. On biopsy, it came out to be breast cancer and this was ER positive. Tamoxifen was given to the patient. Tamoxifen was given to the patient. Tamoxifen increases the risk of. Okay. So before discussing this question in detail, let us discuss the important points related to tamoxifen. So see first, this tamoxifen is approved for primary prophylaxis of breast cancer in high risk women. Okay, first point. So prophylaxis, primary prophylaxis of breast cancer in high risk women. Now you can see it reduces the recurrence rate of breast cancer in ipsilateral as well as the contralateral breast, and it is associated with reduced risk of cancer in contralateral breast. One point. Question is asked, what is the dose of tamoxifen? It's 10 mg BD for 5 years. So it's given at least 10 mg BD for 5 years. Then there are two questions. For hormone therapy in premenopausal patients, what is the drug of choice? It's tamoxifen. And in postmenopausal patients, it's the aromatase inhibitors. Now how it acts? So this tamoxifen is potent antagonist. This is potent antagonist on breast cancer cells and on blood vessels. Potent antagonist. Clear? And it is having partial agonistic activity. Partial agonistic activity on pitbull. Pitbull means, pit means pituitary, B means bone, U means uterus, and L means liver. Clear? So it is having partial agonistic activity on pituitary, bone, uterus, liver. We are concerned about what? Uterus. So since there is partial agonistic activity, what is the main problem? Yes, especially in postmenopausal patients. In postmenopausal patients, because of this partial agonistic activity, what happens? There is increased risk of endometrial cancer, and in postmenopausal patients already there is increased risk of endometrial cancer. So the main problem of this is there is increased risk of endometrial cancer. Clear? We can give this drug in postmenopausal patients for hormone therapy. We can, but we are not giving. Why? Because of this particular complication. Clear? So it increases the risk of endometrial cancer. So now see the question again. Tamoxifen increases the risk of breast carcinoma in opposite breast? No, it reduces the risk. Second, endometrial carcinoma? Yes. Risk of CML? No. Ovarian cancer? No. So correct answer for this question is endometrial carcinoma, and that is B. Now see this question. Appropriate FNAC specimen in case of thyroid contains. So generally the adequate FNAC specimen should contain at least 6 follicular cell groups. So how many cell groups? 6 follicular cell groups, and at least there should be presence of 10 cells in each group. Clear? Now see what other book says. Now see this statement. Most cytologists consider a satisfactory smear to contain at least 6 clusters, of well preserved cells, and each group must be composed of at least 10 cells from separate aspirate. Clear? Now see what's written here. So most cytologists consider a satisfactory smear to contain at least 6 clusters of well preserved cells, and each group must be composed at least 10 cells from separate aspirate. Clear? So for this question the correct answer is B, means appropriate FNAC specimen in case of thyroid contains 6 follicular cell groups containing 10 to 15 cells each. Now see this question. Which of the following is least commonly injured nerve during thyroid surgery? So asking least common complication, least common site, least commonly injured is a fashion nowadays. You will notice that in NEET as well as in AIIMS, generally one question is asked in similar pattern: least common site, least commonly injured, least common complication. So let's rule out. Question is asked, what is the most common complication of what is the most commonly injured nerve in thyroidectomy? So most commonly injured nerve is external branch of superior laryngeal nerve. So the most commonly injured nerve during thyroidectomy is external branch of superior laryngeal nerve, also known as external laryngeal nerve. Clear? Be careful, it is not the recurrent laryngeal nerve. Recurrent laryngeal nerve is also injured. Clear? Now see the problem. Generally in thyroid surgeries, if we are also operating the lateral side of neck, so if the lateral neck surgery is also done along with the thyroid surgery, then what is the problem? This marginal mandibular nerve is also injured. And especially in robotic assisted thyroidectomy, whenever we are using this oral approach, transoral approach, in this case also what happens, there is injury of marginal mandibular nerve, but this ansa cervicalis is not the injured nerve, it's not injured. And what is the use whenever recurrent laryngeal nerve is injured, especially when we are going to excise the part of recurrent laryngeal nerve, when it is involved by malignancy, we are using ansa cervicalis for reconstruction of recurrent laryngeal nerve. Now see the literature. Now see the complications of thyroidectomy. There is hemorrhage because of slippage of ligature, especially from superior thyroid artery, or there is bleeding from muscular artery. Sometimes it can lead to tension hematoma, and because of that, in post-operative period, patient might be having dyspnea or stridor. In those cases, we have to shift the patient immediately to OT, open the sutures, ligate the bleeding vessel, control the hemostasis, and then close the wound after inserting the drain, right? Then there are certain other causes of respiratory obstruction. One is tension hematoma. Second, it can be because of laryngeal edema, and this is the most common cause of respiratory obstruction, especially after thyroidectomy. What is the laryngeal edema because of anesthetic intubation? Third important cause is what? Bilateral recurrent laryngeal nerve palsy, but it is not very common. So question is asked, what is the most commonly injured nerve? The most commonly injured nerve during thyroid surgery is external laryngeal. Other nerves which are injured, one is recurrent laryngeal, and there might be injury of cervical sympathetic trunk. Another question is asked about thyroid surgery complication, that parathyroid insufficiency occurs on which day? Second to fifth day. So it occurs on second to fifth day. It leads to hypocalcemia, and what is the cause? There is vascular infarction whenever we are going to ligate the inferior thyroid artery away from thyroid. And this question is frequently asked. Thyrotoxic crisis in AIIMS, that what is the most common cause of thyrotoxic crisis in hyperthyroid patient is the inadequate preoperative preparation. Means you didn't make that patient euthyroid and you are performing surgery, there is release of thyroid hormones during surgery leading to thyrotoxic crisis. This is the basic question. After that, so you saw that external laryngeal nerve and recurrent laryngeal nerve is commonly injured. Now see, so in this book there is robotic assisted thyroidectomy which is mentioned nicely. And what are the approaches for robotic assisted thyroidectomy? There is transaxillary approach, retroauricular approach, and transoral approach. Okay, so whenever we are using this retroauricular approach specifically, in this case what happens, there is mouth corner deviation from indirect injury to marginal mandibular nerve. Clear? So generally this marginal mandibular nerve injury is not very common during open surgery, but in robotic assisted thyroidectomy it is seen. Now see here in this book what is mentioned, patient who undergo lateral neck surgery in association with thyroid surgery. Lateral neck surgery in association with thyroid surgery, they have additional risk of neurovascular injury, which include shoulder weakness because of injury of spinal accessory nerve, so cranial nerve 11, tongue weakness because of injury to hypoglossal or injury to cranial nerve 12, and C, lower lip weakness because of marginal mandibular nerve injury. And this question was asked indirectly also in AIIMS, that in parotid surgery, if a patient is having lower lip weakness, yes, it is because of injury of which nerve? So it is because of marginal mandibular nerve. So here answer is clear that obviously it is not the recurrent laryngeal nerve, it is not the superior laryngeal nerve, it's not the marginal mandibular nerve. So generally the answer is ansa cervicalis, generally it's not injured. So what is the role of ansa cervicalis, or what is the relation of this nerve in relation to thyroid surgery? So see, in thyroid surgery, when recurrent laryngeal nerve is injured, so this is used as a graft. Now see what Bailey says: if recurrent laryngeal nerve is injured during surgery and transected ends are identified, they should be re-anastomosed. 1. In event that length of nerve is excised due to invasion by malignancy, the anastomosis of ansa cervicalis, can you see? Anastomosis of ansa cervicalis may be considered. What is the advantage? It does not return the mobility of vocal cord, but advantage is it is going to maintain the neurological input to the muscles of larynx. Clear? So this is the relation of ansa cervicalis with respect to thyroid surgery. So here the correct answer for this question is A, that is ansa cervicalis. So this is a repeat question, it was asked many times. MELD score, and there is another question which is being asked, that is Pel score. So what is the full form of MELD score? Model for end stage liver disease, and the component for this MELD score is CBI. Clear? Mnemonic is CBI. C means creatinine, B means bilirubin, and I means INR. Clear? The second is Pel score, and the Pel score is pediatric end stage liver disease. And what's the mnemonic for Pel score? The mnemonic is NABIA. It's NABIA. Clear? So N means it's the nutrition, A means age, B means bilirubin, I means INR, and A means albumin. Clear? So be careful, albumin is a component of Pel score. It is not the component of MELD score. So correct answer for this question is what? D. It's the albumin. Pel score and MELD score are frequently asked nowadays. Let's discuss in detail. So what is the use of this MELD score? It is used to assess the severity of chronic liver disease. And initially this MELD score was developed to predict death within 3 months of surgery for the patients who had undergone TIPS. Clear? So the components are CBI, creatinine, bilirubin, and INR. And C, by UNOS, United Network for Organ Sharing. It is used for organ allocation in liver transplant recipients. And it is 6 to 40 point scale. 6 to 40 point scale. MELD score. Now see the PELD. So we discussed the mnemonic is NABIA, that is nutrition, age, bilirubin, INR, and albumin. So these are the two questions which are frequently asked, and it is very easy to remember. MELD score by CBI and PELD score by NABIA. Now see this question. In a patient with recurrent abdominal pain, ultrasound was done and it's normal. Clear? Further evaluation by other investigations, he was found to have biliary dyskinesia. So one problem, this patient is having biliary dyskinesia. And what is written in the question? That ultrasound is normal. Ultrasound is normal. Clear? So which of the following is not done for the diagnosis of biliary dyskinesia? So you can solve this question by common sense also. So if ultrasound is normal in this condition, obviously ultrasound cannot be used for the diagnosis. So what? Generally, it is not diagnosed by ultrasound. So this is based on common sense. By the way, we are going to discuss in detail this biliary dyskinesia. It is also known as sphincter of Oddi dysfunction. Now see the problem, whenever we are going to take fatty meal, after fatty meal, what? there is increased secretion of bile, and this bile is being secreted, bile is being ejected out of gallbladder, and this is supposed to enter into duodenum for digestion of fat. But what is the problem? In sphincter of Oddi dysfunction, what is the problem? There is functional blockage of this sphincter. So what's the problem? There is functional blockage of this sphincter for bile duct as well as sphincter for pancreatic duct. Now what is the problem? If there is functional blockage inside the CBD, what is the problem? There is increased pressure. So there is increased pressure inside the CBD as well as in the pancreatic duct. So there is increased basal pressure, and that's why these patients are going to have biliary colic. Clear? And these patients are going to have acute pancreatitis. Clear? So there is biliary colic or there is acute pancreatitis. Clear? But what is the problem? So in this case, can you see there is functional blockage of sphincter? If we are going to use smooth muscle relaxants like nitrates, so in this case, if we are going to use the nitrates which are smooth muscle relaxant, it is going to decrease the pressure of sphincter and it is going to relieve the condition temporarily. Clear? Now the problem. In this case, the problem is that there is increased pressure where? Of the sphincter. So if you are going to measure the pressure, yes, you can confirm the diagnosis. So how we are going to measure the pressure? The gold standard investigation for this condition is ERCP plus manometry. Gold standard is we are going to measure the pressure. So it's the ERCP plus manometry of which sphincters? Obviously biliary and pancreatic sphincters. Second, if we are going for HIDA scan, what is the problem? In HIDA scan, there is delayed biliary transit. So what? You will notice that the tracer is not going into duodenum. There is delay. So on HIDA also you can make the diagnosis. On HIDA scan, there is delayed biliary transit. Clear? Now third problem. Some patients who are having gallstone disease, okay, and they have biliary colic for that, and we generally perform what? Lap cholecystectomy. If that patient is having sphincter of Oddi dysfunction, even after cholecystectomy, that patient will be having biliary colic. So in follow-up, after surgery, patient will be coming to you with biliary colic. And if you're not able to diagnose that what's the cause, you should suspect what? Biliary dyskinesia or sphincter of Oddi dyskinesia. Clear? So here you saw that for evaluation, the gold standard is ERCP plus manometry. So we are using this. Clear? We are using HIDA scan. In post-surgery follow-up also you can make the diagnosis, but generally ultrasound is not diagnostic. There is a clue on ultrasound. Sometimes you might find dilated CBD on ultrasound. Clear? Right? But it is not diagnostic. So correct answer for this question is D. Now see what's written in Bailey. First statement, biliary type sphincter of Oddi dysfunction should be considered and excluded in patients with post cholecystectomy syndrome. Clear? Now pancreatic type, when there is spasm of pancreatic sphincter or in functional blockage of pancreatic sphincter, should be excluded in patients with recurrent acute pancreatitis with unexplained etiology. Okay? Now see, a careful history is essential. CT and MRCP can demonstrate the dilatation of biliary and pancreatic duct. Now see, MRCP with intravenous secretin injection can particularly demonstrate pancreatic duct dilatation due to raised sphincter pressure. So this is the basic problem. There is functional blockage and that is intermittent. Endoscopic ultrasound is also helpful, but here is the quantitative cholecystography, means HIDA scan. On HIDA scan, there is delayed biliary transit, and the question is asked, what is the gold standard for diagnosis of sphincter of Oddi dysfunction? And it's ERCP with manometry of biliary and pancreatic sphincter. Clear? So for this question, the correct answer was ultrasound. Now see this question. ERCP is used in all of the following except, okay? See, ERCP is generally used in cases of recurrent pancreatitis. Why? First, that what is the etiology, and sometimes if there is some obstructive pathology or etiology, ERCP is used to relieve the obstruction, and sometimes it is used to put the stent. Second, in periampullary carcinoma, now see the problem. This is the gallbladder, this is the bile duct. What happens in periampullary carcinoma, especially the ampullary carcinoma? We perform ERCPY to perform or to take the brush biopsy. So generally ERCP is done to take the brush biopsy. Second, sometimes in patients of periampullary carcinoma to relieve jaundice, what we are going to perform ERCP to put the stent. So for stenting in periampullary carcinoma, we perform ERCP. For taking brush biopsy, we perform ERCP. If a patient is having unexplained jaundice, in that case also, to see what's the etiology and to relieve the jaundice, we perform ERCP. And generally, in patients of pancreatitis, acute biliary pancreatitis, what kind of acute biliary pancreatitis, especially the patients who are having cholangitis and the patients who are having choledochal cyst in which there is cholangitis, we perform the ERCP. But ERCP in patients of pancreatitis without cholangitis or choledochal cyst, it's not having role. Now see what substance says. ERCP, early ERCP with or without sphincterotomy was initially advocated to reduce the severity of pancreatitis. Clear? But see, however, 3 randomized trials had demonstrated that ERCP is beneficial only for patients with severe acute biliary pancreatitis. And that's why routine use of ERCP is not indicated for patients with mild pancreatitis. Why? Because generally in these cases, the bile duct obstruction is usually transient. Clear? And it resolves within 48 hours after the onset of symptom. Means, first, we have to perform it in severe acute biliary pancreatitis. Second, apart from acute biliary pancreatitis, severe acute biliary pancreatitis, it is indicated for the patients who develop, be careful, cholangitis and persistent bile duct obstruction demonstrated by other modalities. Clear? So see this question again. For this question, ERCP is used in all of the following except pancreatitis without features of cholangitis or choledochal cyst. Now see this question, which of the following is indicative of complete what? Complete large bowel obstruction. Okay, so let us discuss some important concepts of large bowel obstruction first. You can see this is the large bowel. Clear? Okay, so first question, what's the most common cause of large bowel obstruction? So the most common cause of large bowel obstruction is malignancy. It's the malignancy. Most common cause of small bowel obstruction is adhesions. Okay, in malignancy, which malignancy and what's the most common site? The most common site is what? Rectum followed by sigmoid. Clear? So see, here is the malignancy, either in the rectum or in the sigmoid colon. Clear? Now you can see what is the name of this valve. This is IC valve, ileocecal valve. So what is the problem? In majority of large bowel obstruction, you can see that it's a type of closed loop obstruction. Yes, because IC valve is competent. So it's a closed loop obstruction, and because of this, what generally the large bowel obstruction is real emergency because there is no chance of proximal decompression, and that's why vomiting is also not seen. But in small bowel obstruction, what's the problem? Because bowel is sensitive to stretch. In small bowel obstruction, patient is having multiple episodes of bilious vomiting. So in small bowel obstruction, patient is having colicky pain, multiple episodes of bilious vomiting, non-passage of feces and flatus, that's known as absolute constipation or obstipation. In this case also there is colicky pain in lower abdomen, but here there is abdominal distension. At the place of bilious vomiting, there is abdominal distension and obstipation. One difference. Clear? Now see the options. High pitched bowel sounds with passage of flatus. If there is passage of flatus, it is going to rule out the complete obstruction. Clear? Second, X-ray showing dilated loops of intestine. Yes, with plica circularis. Now this plica circularis, this is seen in small intestine. These are characteristic feature of small intestine. This is not seen in large bowel or large intestine. Bilious vomiting is again a feature of small bowel obstruction. It's generally not seen in large bowel obstruction. In large bowel obstruction, we saw there is abdominal distension. Clear? And see X-ray showing dilated bowel loops with prominent horstrations. So yes, it is seen in large bowel obstruction. And generally, how to see whether there is complete obstruction? There is absence of gas in rectum. Absence of gas in rectum. Clear? So you must be knowing the differences between small bowel obstruction and large bowel obstruction. In small bowel obstruction, the loops are placed centrally. Yes, narrow in caliber. But in large bowel obstruction, it is placed peripherally, wider in caliber, and there is presence of horstrations. How it looks like? So here you can see that these are the loops placed peripherally. You can easily make out also what? That this is ascending colon, transverse colon, descending colon, and you can make out what? These are the horstrations. Clear? These are placed peripherally. In small bowel loops or in small bowel obstruction, the loops are placed centrally, narrow in caliber, and there is no horstrations. In jejunum, there is circumferential ring-like pattern, and that is known as volvuli conniventis. And in ileum, there are no features. So ileum is characteristically characterless or featureless. So these are the important points related to large bowel obstruction. So obviously, for this question, the correct answer is D. Now see the literature. First, mucosa of small bowel is characterized by transverse folds, and that is known as plica circularis, which is prominent in distal duodenum and jejunum. Okay, one. Second, signs and symptoms of large bowel obstruction depends on the cause and location of obstruction. Now see, rectum and left colon, cancers arising from rectum and left colon are more likely to obstruct than those arising from more capacious proximal colon. You know this principle also, that there is progressive narrowing of lumen in small bowel as well as large bowel. That's why what happens? Duodenum is widest, ileum is narrowest. Similarly, there is progressive narrowing of colon also. So cecum is widest, sigmoid is narrowest. So right colon is relatively wider as compared to left colon. That's why if malignancy is there, bleeding is more common on right side and obstruction is more common on left side. Regardless of the cause of blockage, the clinical manifestations of large bowel obstruction are failure to pass stool and flatus, associated with increasing abdominal distension and cramping abdominal pain. So generally there is no vomiting. Now see here, large bowel except for cecum shows haustral folds, which unlike volvuli conniventis are spaced irregularly. In volvuli conniventis, there is regularly spaced ring-like pattern. So circumferential ring-like pattern. It is seen in jejunum. Do not cross the whole diameter of bowel and do not have indentations placed opposite one another. Clear? So for this question, it's clear that correct answer is D. X-ray showing dilated bowel loops with prominent horstrations. Now see this question. 65 years old male, okay, presented to emergency with abdominal pain for 6 hours duration. On examination, how much is the blood pressure? Can you see? 90/50. How much is the respiratory rate? Yes, 24 per minute. It means this patient is having hypotension, this patient is having increased respiratory rate. Saturation, see the saturation. Saturation is hardly 92%. So 92% is the oxygen saturation. Okay. Now see, abdominal X-ray showed extraluminal air in abdomen. So presence of extraluminal air, hypotension, low saturation, all these favors the diagnosis of perforation peritonitis. So this patient is having perforation peritonitis. Clear? And what's the problem in this case? Because of this perforation, the intraluminal content is going to collect in the peritoneal cavity, and after that what? There is third space loss. Fluid is also collected into the peritoneal cavity, and because of this third space loss, when patients are coming to us, generally they have what? Hypotension. Clear? So what happens? Even before sending these patients for investigations, in these cases, first on the basis of suspicion only, clinical findings, we are going to resuscitate the patients. So we give IV fluids, we give IV antibiotics, we insert Ryle's tube, we insert Foley's catheterization, and whenever the urine output is 1 ml per minute, means patient is resuscitated, there is adequate tissue perfusion, we are sending the patients for investigation. Clear? So first we resuscitate the patient, and then only we take these patients for surgery. So see, which of the following must be done before shifting the patient to OT? Intubate the patient, not required, because even if you are going to resuscitate the patient, correct the dyselectrolytemia, patient will improve. Initial IV access of choice is central venous catheter. No, we insert green cannula, 2 green cannula. Clear? For resuscitation. So CVP line insertion or central line insertion is not mandatory. Confirm the diagnosis with CT. No. Presence of extraluminal air means the gas under diaphragm is diagnostic. So no need for CT because the patient is unstable. Infusion of 2 to 3 liters of crystalloids. Yes, we have to resuscitate the patient and correct the dyselectrolytemia. So correct answer for this question is D. Now see what is written in Bailey and what literature says. So management of peritonitis. First, can you see correction of fluid and electrolyte imbalance. Then insertion of nasogastric drainage tube and urinary catheter. Broad spectrum antibiotic, analgesia and vital system support. And the surgical treatment of cause when appropriate. So first resuscitation and then surgical treatment. Remove or divert the cause, peritoneal lavage plus minus drainage. So it's very important for the patients of perforation peritonitis that we should go for the correction of fluid loss and circulating volume, because these patients are frequently hypovolemic with electrolyte disturbances. Here we have to restore the plasma volume. So plasma volume should be restored and ongoing losses corrected. Clear? So in this question we should go for infusion of 2 to 3 liters of crystalloids. Now see this question. A male patient is diagnosed with carcinoma colon. Okay. Which of the following is correct sequence of gene mutation? So actually speaking, if you see the options given, this question is related to Fearon-Vogelstein adenoma carcinoma multi-step model. Adenoma carcinoma multi-step model. Clear? This question is asked in medicine also, surgery also, pathology also. So see what is this Fearon-Vogelstein adenoma carcinoma multi-step model. So in this case, initially you can see there is normal colonic epithelium and there is which mutation? APC gene mutation. Because of this APC gene mutation, you can see there is dysplastic aberrant crypt foci. So what happens? tumor initiation. Then there is formation of early adenoma, and then there is KRAS mutation. And because of this, early adenoma is converted, or it is converted into intermediate adenoma. Then there is DCC mutation. DCC full form, deleted in colorectal cancer. It's deleted in colorectal cancer. And because of this, there is formation of late adenoma, and there is P53 mutation, and then there is carcinoma. So this is adenoma carcinoma multi-step model, and the name is Fearon-Vogelstein. So what is the sequence? First APC gene, then KRAS, then DCC, and then P53. Clear? So it is APC gene followed by KRAS followed by DCC followed by P53. Can you predict who is the next Bollywood star? Most probably Akshay Kumar is going to be the next Bollywood superstar. Clear? So how to remember? AKDP, Akshay Kumar's DP. So the sequence is AKDP. Clear? So it is APC followed by KRAS followed by DCC followed by P53. So obviously what is the correct answer? APC followed by KRAS, DCC, P53. So this is in relation to Fearon-Vogelstein adenoma carcinoma multi-step model. So correct answer is B. Now see this question. Mesh used for hernioplasty should be. Before discussing this question, let me tell you, similar questions were asked previously in NEET, and they asked about lightweight and heavyweight meshes. So what should be the weight of lightweight meshes? The weight should be less than 40 grams per meter square. And what should be the weight of heavyweight meshes? In heavyweight meshes, the weight is more than 80 grams per meter square. Simple concept. Now, it's very easy to understand. See, suppose this is a mesh. Okay, A and B, both of these are having almost similar area. Now see, in the meshes, there is a large pore mesh, and there is a small pore mesh. Okay, what is the meaning? See, if you see the first one, in the first one, these are the strings or threads, and in the second one, can you see, these are the threads. Clear? So if you see the weaving pattern, yes, it's like this. So in the first one, or A, you can see the size of pore is large, so obviously it's large pore. And in second, the size of pore is small, so obviously it's the small pore. This one is large pore. Okay, simple. So generally, question, the large pore meshes are lightweight or heavyweight? So obviously the large pore meshes are lightweight. So generally large pore meshes are lightweight meshes. Clear? So why this lightweight large pore meshes are preferred? Why? Because there is ingrowth of tissue. So there is better tissue. So there is better tissue integration, and there is less shrinkage. So that's why lightweight large pore meshes are preferred in hernia surgery. Clear? So see, the mesh used for hernioplasty should be heavyweight large pore, no. Lightweight small pore, no. Heavyweight small pore, no. Is the lightweight large pore. Now see what's written in the Bailey. So first question which is asked related to mesh. Meshes can shrink by up to 50%. So first, meshes can shrink how much? This is first question. Up to 50%. Potential question. And in occasional cases even more. Meshes with thinner strands and larger spaces between them. Lightweight, can you see? Large pore meshes are preferred because they have better tissue integration, less shrinkage, more flexibility, and improved comfort. So for hernia surgery, which mesh is preferred? Lightweight large pore. Lightweight large pore. Clear? So lightweight, large pore meshes are preferred. After that, the term light, medium and heavy are not precisely defined, but meshes less than 40 grams per meter square are lightweight and more than 80 grams per meter square are heavy. So the second question which is asked, lightweight meshes less than 40 gram per meter square and heavyweight meshes more than 80 grams per meter square. Okay. After that, third, suppose this is the defect and we are using the mesh. So if there is a defect and we are using the mesh, generally how much overlapping of margins should be there? So there should be at least 2 to 5 centimeter of overlapping of margin. So we should cover at least defect with 2 to 5 centimeter of margin all around the defect. So the margin all around the defect should be covered minimum 2 centimeter and maximum 5 centimeter. So the potential questions are, how much mesh can shrink up to 50%? Lightweight is less than 40 gram per meter square. Heavyweight weight is more than 80 grams per meter square. And how much overlap of defect should be there? At least 2 to 5 centimeter around the defect. This is a new question. See, prostate needle biopsy by single core shows acinar adenocarcinoma. So there is acinar adenocarcinoma, predominant poorly formed glands in cribriform pattern, followed by crowded but separated glands and a minor component of single cell infiltration. So see the findings, important findings first. Predominant poorly formed glands. Okay, and which pattern? In cribriform pattern. Cribriform pattern. Okay, so let's first see the Gleason grading for prostate. We follow Gleason grading. So let's see the Gleason grading and then we can easily crack the question. Now see the new grading system. So if you see the grade 1, in this only individual discrete and well formed glands are there. So here well formed glands were not there. Second, in grade 2, predominantly well formed glands and lesser component of poorly formed, fused or cribriform glands. Now see the grade 3. Can you see? Predominantly poorly formed, fused or cribriform glands with a lesser component of well formed glands. So in this picture also, so in the question also, what there was predominantly poorly formed gland and cribriform gland. So correct answer is grade 3. By the way, see what happens in grade 4. Only poorly formed, fused cribriform glands. Be careful. Only poorly formed, fused cribriform glands are predominantly well formed glands with a lesser component lacking, or predominantly lacking glands with a lesser component of well formed glands. And what happens in grade 5? Grade 5 lacks gland formation or with necrosis, with or without poorly formed, fused or cribriform gland. So according to this description, what fits for our answer? It's the grade 3. So you saw in grade 3 predominantly poorly formed, fused cribriform gland with a lesser component or well formed gland. So correct answer for this question is B, and that is what? Grade 3. Now see this question. A 23 years old male was burnt with bursting of stove. There is singeing of hair in his face and burns covered the chest on both sides and front of both upper arms. Calculate the percentage of burns. So you can easily calculate it and you have to apply the rule of 9. So here let's calculate. Since face is involved, means this head and neck part, so it's 9% both front and back. After that, the front of, can you see, the front of both upper arms. So if only front of both upper arms are involved, clear? So how much? 4.5 on each side. So total 9% of both of these arms. After that, burns covered the chest on both sides. Clear? So 18% is front of chest and abdomen and 18% is for the back. So for chest only it's 9%. So how much is total? This is for face, means head and neck. This is for both arms, front side, and this is for chest, both sides. So total is 9 plus 9 plus 9, so it's 27%. So here the total burned surface area involved is 27%. So correct answer for this question is C. Now see, almost every year there is one question related to parotid surgery or complications of parotid surgery. Okay, so see, a patient after parotid surgery on awakening noticed lower lip paralysis. So there is lower lip paralysis after parotid surgery. Which of the following is most likely injured? Okay, so you must be knowing that there are 5 branches of facial nerve in relation to this parotid gland. So first have a look of those 5 branches and anatomy, and then we will discuss the question. So questions are asked, what are the 5 branches in relation to the parotid gland? So first is, this is temporal branch of facial nerve. Then there is zygomatic branch, buccal branch, marginal mandibular branch, and fifth is cervical branch. Okay, now see, this is the lower lip. So if you see the lower lip, and you can see which branch is supplying the lower lip region. So generally the muscles of this lower lip are mainly supplied by which one? This marginal mandibular branch. Okay, now see what is written in grays and see the literature related to parotid duct complications, parotid duct surgery complications. ये part edit कर देना. Now see, in relation to the lower lip, generally this marginal mandibular branch is going to supply the muscles in relation to the lower lip. So let's see what is written in grays related to the marginal mandibular nerve and nerves injured during parotid surgery. Now see, marginal mandibular branches of facial nerve, the branches supply risorius and muscles of the lower lip, right? Chin and filaments communicate with mental nerve. Okay, now see this which is mentioned in the grays. Facial nerve is routinely isolated as a part of superficial parotidectomy operation. Okay, typically in the treatment of parotid tumors, when that part of gland lying superficial to the plane of facial nerve is removed along with the tumor. Now see, although this can affect all branches of the facial nerve, but the weakness is often confined to the territory invaded by marginal mandibular nerve. So the weakness is often confined to the territory innervated by the marginal mandibular branch. Clear? And which is most likely to be stretched during surgical intervention and manifested by weakness of lower lip on the affected side. Clear? So important points, most likely involvement of which branch? The marginal mandibular branch, and manifested as weakness of lower lip on the affected side. Clear? So answer is clear that in this question, what is the correct answer? Is the marginal mandibular nerve or mandibular branch. So see the question again. A patient after parotid surgery on awakening noticed lower lip paralysis. Which of the following is most likely injured nerve? And it's the mandibular branch of facial nerve. So it's an easy question, and this question was asked many times. What is the full form of FAST, or FAST stands for? So it is focused assessment with sonography for trauma. Focused assessment with sonography for trauma. So correct answer here appears focused assessment sonograph of trauma. So correct answer for this is B. Since the next question is also in relation to FAST, let's first discuss FAST in detail. So this is focused assessment with sonography for trauma. So generally in FAST we are going to assess 4 P's. So what are these 4 P's? Pericardial sac, perihepatic region, perisplenic region, and pelvis. Okay, and for 4 P's, how many minutes are required? 4 minutes. So what you are supposed to remember, that for 4 P's, it is done within 4 minutes. So generally, it is done within 2 to 4 minutes. Clear? Now, question is asked, what is the first investigation done in patients of blunt trauma abdomen? Whether patient is stable or unstable. First investigation done in patients of blunt trauma abdomen is what? Fast. Now what? In fast, only 4 P's are assessed. But if you are going to extend it to right thoracic as well as left thoracic region, this is known as E-fast. E-fast means extended fast. After that, in which sequence you are going to perform the fast? So first, for pericardial. So question is asked that in which sequence you are going to perform the fast. So first is for pericardial sac, after that for perihepatic region, after that for perisplenic region, and after that it is performed for pelvis. After that, the question is asked for pericardial sac, which view is used? So for pericardial sac there is sub-xiphoid transverse view. For perihepatic region, which view is there? There is right upper quadrant longitudinal view. For perisplenic region, it's left upper quadrant longitudinal view. And if you see the pelvis, for pelvis we have suprapubic, longitudinal and transverse view. So how many views in fast? 4. See, now we are going to extend it to visualize the right thoracic and left thoracic region. So in fast there are 4 views, but in E-fast, how many views? In E-fast there are 6 views. Clear? This E-fast was asked many times in AIIMS, and the question was, on E-fast in pneumothorax, which sign is seen? So in pneumothorax on E-fast there is stratosphere sign, also known as barcode sign. So there is stratosphere sign and or barcode sign. Clear? So what? You can easily assess the hematoma or collection of fluid in pericardiac region, perihepatic, perisplenic and pelvic region. But what is the biggest problem of ultrasound? Means the fast, that it is difficult to assess the retroperitoneum, or it is difficult to assess the retroperitoneal hematoma. So see this question. In fast, which of the following site cannot be evaluated? So we can evaluate the pericardial fluid, we can evaluate the renal hematoma, we can evaluate the liver injury. Clear? But what? Retroperitoneal hemorrhage, it is very difficult to assess. Now see what's written in Bailey. Utilization of E-fast detects free fluid in abdomen or pericardium. Clear? Not reliably detect less than 100 ml of free blood. So this is also a question. At least how much blood should be there? 100 ml. Does not directly identify injury to hollow viscus. Cannot reliably exclude injury in penetrating trauma. May need repeating or supplementing with other investigations. That's why if the patient is stable and fast is positive, we have to confirm the diagnosis with CCT. And see here, this is the question. It is unreliable for the assessment of retroperitoneum. It is fast is unreliable for the assessment of retroperitoneum. Clear? So for this question, the correct answer is B, that retroperitoneal hemorrhage cannot be evaluated with fast. Now see this question. Which of the following statement is true about retroperitoneal hematoma occurring after trauma? Retroperitoneal hematoma related questions were asked many times in AIIMS. They asked what are the various zones. Clear? So before discussing the options, we should first discuss what are the various zones and how we are going to manage the injuries of those various zones. So now see the zone. This is zone 1 and this zone 1 is central. This is central. This is the zone 2 and this zone 2 is lateral. It's lateral. This is zone 3, this whole region, and this one is what? Pelvic. And generally it's not given in the books. In some journals it's given. There is zone 4 also, and this zone 4 was asked in AIIMS. And what is this zone 4? It includes portal and retrohepatic area. Clear? Now see the extent of zone 1. If you see the extent, it extends from esophageal hiatus to sacral promontory. So if you see here, what is included in zone 1? In zone 1, we are going to include what? Abdominal aorta. Can you see? After that, what? Inferior vena cava. So this part, inferior vena cava. And their proximal branches, means proximal branches of aorta and the tributaries of IVC. Clear? If you see this zone 2, the extent of zone 2, the lateral diaphragm, from this lateral diaphragm to the iliac crest. And what is included in zone 2? Distal renal arteries and vein, means it is in relation to kidney. So zone 2 is in relation to kidney, mainly the vessels, renal artery and veins, and which part? Distal part. Now see, in zone 3 here, it is the retroperitoneal space of pelvic bowl, and here we are going to include iliac artery and iliac vein. And we discussed that in zone 4 we are going to include the portal and retrohepatic area. Now see what is written in substance related to the management of retroperitoneal hematoma. So see, zone 1 hematoma require exploration. Why? Because these are frequently involving aorta, proximal visceral vessels, or inferior vena cava. Clear? Now see, injuries to retrohepatic vena cava are best served by not exposing the content, low pressure injury, and gently packing the surrounding area. Now see the zone 2. A hematoma in the region of zone 2 predominantly contains kidneys. And be careful, generally we should not explore. So here, should be explored only if it appears that hematoma is expanding and continuing to lose blood. Clear? And what about zone 3? Hematoma in zone 3 is secondary to pelvic fracture bleeding. Should not be explored unless exsanguinating hemorrhage is obvious. So now see, we are basically bothered about zone 2. In zone 2, usually we are not going to explore the hematoma. But see, during laparotomy, penetrating trauma to the retroperitoneum in the vicinity of kidney should be explored. Why? To ensure hemostasis. Clear? But we have to assess for urine leak also. Clear? So if you see the management of retroperitoneal zones, this is for zone 1. Clear? So central hematoma should always be explored with proximal and distal vascular control. This is for zone 2, which is lateral hematoma, usually renal in origin, and can be managed non-operatively, sometimes with angioembolization, until and unless there is penetrating trauma and exsanguinating hemorrhage is going on. What about zone 3 or pelvic hematoma? In zone 3 or pelvic hematoma, these are difficult to control, so generally we are going to manage it by packing and angioembolization. In the option, there is one option related to Mattox maneuver. So see what we are going to do in Mattox maneuver. So what is the other name of this Mattox maneuver? It is also known as left medial visceral rotation. Okay. Now see, this is the midline. So what we are going to do, you can see that this is the left colon, this is the left kidney, this is the spleen and pancreas. Clear? So you can see left kidney, left colon, spleen and pancreas. These left sided viscera is brought to the midline, and that's why what's the name? Left sided medial visceral rotation. After this Mattox maneuver, which part is exposed? Generally you are going to see what? Abdominal aorta. Clear? What else? The celiac axis, superior mesenteric artery. Clear? And this part, this is the renal artery. Which part? Proximal renal artery. Clear? So it is going to expose what? Aorta, celiac axis, superior mesenteric artery, which aorta, abdominal aorta, and the proximal part of renal artery. Clear? And generally it is recommended for drainage of central supramesocolic hematoma. Clear? So you have basic idea about zones, Matox maneuver and management. Now let's discuss the options. So zone 2 means lateral hematoma, penetrating injuries hematoma. Surgical exploration should be done always. Yes, if there is penetrating injury, we have to go for surgical exploration. Otherwise, it is generally managed by angioembolization. Matox maneuver to explore aorta involves mobilization of ascending colon to right. No, ascending colon is always already on the right side. The Matox maneuver is left medial visceral rotation. So we discussed left colon, left kidney, pancreas and spleen is brought to the midline. So this option is incorrect. Penetrating trauma in the pelvic region should be explored. No, generally it should not be explored. Clear? Initially we are going to manage it by angioembolization or by packing. In zone 1, injured vessels embolization is done. In zone 1, you saw that major vessels aorta and vena cava are located. And if there is injury of these structures, we have to go for what? Surgical intervention with proximal and distal control. So embolization is generally not done. So correct answer for this question is A, that in zone 2 specifically in cases of penetrating injury or exsanguinating hemorrhage, we should go for surgical exploration. So correct answer for this question is A. Now see this question. A 38 years old female was brain dead. She signed for organ donation previously. Family members also accepted. Which of the following patient is ideal recipient? So this female patient who is a brain dead, she is going for organ donation. So what is the ideal recipient? Now see the first option. 70 years old female on dialysis for chronic renal failure. Obviously not, because she is having very limited life expectancy. See what's written in Bailey. The age of patient with end stage renal failure accepted for dialysis has risen over the last 2 decades, and in the UK, mean age of patient starting dialysis is around 70 years. There is no absolute upper age limit to renal transplantation, but inevitably, older patients aged more than 65 years are less likely to be considered suitable candidates. Why? Because they have cardiopulmonary disorders, other comorbidities. So obviously we should not go for A. Second, 50 years chronic alcoholic patient with irreversible liver damage. See, if a patient is chronic alcoholic and there is active alcohol abuse, that's an absolute contraindication for liver transplantation. See the contraindications of liver transplantation. So here you can see that active alcohol abuse is an absolute contraindication for liver transplantation. And if you see, if there is ongoing tobacco use or illegal drug use, then also it's a contraindication. So here, in this case also, we will not go for transplantation. Now see, 14 years old boy with multi-organ failure. And if a patient is having multi-organ failure, obviously it's difficult to save the patient by organ transplantations, not the good recipient. And see, fourth, 35 years old female with renal failure. So if a female is young, 35 years old, and there is renal failure, obviously we will go for it. So correct answer for this question is D, 35 years old female with renal failure. Now see this question, a similar question was asked long back. Now see, calculate the calories from TPN containing 100 grams of dextrose, 30 grams of amino acids and 40 grams of lipids. Okay, so it's very easy to calculate. So this table is from Subiston. So from dextrose, how much calories we are getting per gram? 3.4. So for 100 grams of dextrose, 100 into 3.4, so it's 340. So from dextrose you are getting 340 calories. From amino acids, how much? 4 kilocalorie per gram. So it's 4 into 30, so it is 120. And from fat or from lipids, how much? It's 10. So it's 10 into 40. So it's 400. So how much? It's 340, 120, 400. So it's 860. So it is 860. So how much is the calorie provided by 100 grams of dextrose, 30 grams of amino acids and 40 grams of lipids? It's the 860. So you have to remember the values, that from 1 gram of dextrose, how much calorie? 3.4. From amino acids, 4. And from lipids, it's 10. So correct answer for this question is D. Now see this question. Similar questions were asked in AIIMS many times. So a 26 years old male patient with RTA complicated with pelvic fracture has been resuscitated with blood transfusion. So pelvic fracture patient, history of blood transfusion, he was febrile, okay, hypotensive, so low BP, dyspneic and oliguric, so there is decreased urine output. Be careful, CVP was normal. It means the hydration status seems to be adequate. Clear? Now started bleeding from nasogastric tube and from IV sites. So what you are noticing, that patient is having bleeding from nasogastric and IV sites. It means some kind of hemolysis is going on and some kind of hemolytic reaction occurred. Now see, let's rule out. In fat embolism, generally there is similar history, but what happens? There is petechial rash. And how we are going to diagnose this fat embolism syndrome? With Gertz criteria. See the Gertz criteria. So Gertz criteria for fat embolism syndrome, there should be at least one major criteria that include petechial rash, respiratory insufficiency, cerebral involvement. In this question, there is no petechial rash, no cerebral involvement. Then 4 necessary for diagnosis. What? Minor criteria. So what? This retinal change. These are the clues which are given in the exam. Fat macroglobulinemia. So generally in exam you are going to find what? Petechial rash, retinal changes in which you can find fat or petechiae, and fat macroglobulinemia. So these are absent. It means this patient is not having fat embolism. Now see, in hemorrhagic shock, generally CVP is low. And if patient is going to be resuscitated, it might becomes normal. But what is the problem? There is no bleeding from nasogastric tube or from IV sites. So this is also ruled out. In acute adrenal insufficiency also, bleeding doesn't occur. So you are left with only one option, and that is transfusion reaction. Now see the problem. Whenever there is mismatched blood transfusion, there is acute hemolytic reaction. Because of ABO incompatibility, there is acute hemolytic reaction, and this can lead to bleeding, complement mediated hemolysis that can lead to bleeding, and this can also lead to multi-organ failure. So see the complications. Transfusion reactions. Okay, so if antibodies present in the recipient serum are incompatible with donor cells, transfusion reaction will result. And the most severe is which one? ABO incompatibility. There is what kind of reaction? Acute hemolytic reaction. So what happens? There is fatal complement mediated intravascular hemolysis and multiple organ failure. Clear? After that, there was a similar question in AIIMS, image based question. This is the transfusion set, and in the transfusion set, what was the question? This filter was marked and it was asked, what's the name of this filter? So this is leukocyte depletion filter. Clear? What is the problem? See, there are febrile transfusion reactions, and these are generally non-hemolytic, caused by graft versus host response from leukocytes in transfused component. So if this filter is used, this filter is going to filter the leukocytes, and with this form of filter used, what? The transfusion reaction is rare with leukodepleted blood. Clear? So generally, if a patient is having febrile transfusion reaction, what are the symptoms you are going to see? Patient might be having fever, chills and rigors. Clear? So in this question, it's a clear-cut case of mismatched blood transfusion, and because of that mismatched blood transfusion, patient is having what? Acute hemolytic reaction. That's why there is bleeding from orifices, bleeding from nasogastric site and IV site. So correct answer for this question is B. Now see this question, which of the following is not the complication of massive transfusion? Okay, if you see Bailey, in Bailey all these are mentioned, that all these are the complications, and we can see all these complications. Okay, but which one is rarest? Have a look. In cases of massive transfusion, there can be fluid overload, hypothermia, and impaired oxygen delivery capacity of hemoglobin. Why? Because over a period of time, in the stored blood, there is decreased 2,3 dpg. Now see the electrolyte related problems. Patient is having hyperkalemia, hypocalcemia, hypomagnesemia, metabolic alkalosis, and metabolic acidosis, which is rare. These are the abnormalities. We can have both hyperkalemia as well as hypokalemia, but hypokalemia is rarely seen. So what's the cause of hyperkalemia? You can see after massive blood transfusion, the potassium is being liberated from accumulated blood during blood preservation. Clear? But sometimes patient is going to develop hypokalemia. So why patient is going to develop hypokalemia? Because citrate is metabolized to bicarbonate, and because of this patient is having what? Metabolic alkalosis here, and because of this metabolic alkalosis, what happens? Patient is going to have hypokalemia. One. Second, transfused RBCs, sometimes they take the potassium. So if they take some potassium, it leads to what? Hypokalemia. So if you see the question, all complications can be seen, but hypokalemia is rare. Out of these, hypokalemia is rare. So correct answer for this question is C. Now see this question. Generally they ask one instrument almost every year. So what is the name of given instrument? This is Perkins Retractor. Okay. What are the various retractors? Mastoid, jawls and Doynes, how they look like. Now first see the mastoid retractor. This is Whitlaner's mastoid retractor. Okay, you can see the prongs on both sides. Here one side is solid or flat. Clear? So this one is Perkins, this is mastoid retractor. Jawl's thyroid retractor is a self-retaining retractor which is used for raising the skin flaps, and it is self-retaining. So generally it is used during thyroid surgery. And you have seen Doyne's retractor. It is used in gynecological operations, especially pelvic surgeries. So this one is Doyne's retractor used in pelvic surgeries. So you might have seen this in gyneotic, and this one is Jawl's self-retaining thyroid retractor. Jawl's self-retaining thyroid retractor. Here you can see these two are, whenever we are going to raise the skin flap, these two are attached, and with this what happens? You are going to increase the distance between the flaps. So these are the instruments which are important. So we were expecting lots of questions related to COVID, and they asked. So see, all of the following are measures used against COVID-19 except. So if you have seen the ad, Amitabh Bachchan is explaining everything. So by that also you can crack this question. What? We have to wash our hands. We have to use the face mask. And for how much duration? Generally at least 20 seconds. And we are using the hand sanitizers. And how much should be the alcohol content, means ethanol content, at least 70%. So all these three are the measures. So generally 1% glutaraldehyde is not used. 2% glutaraldehyde is used for sterilization of endoscope. That is a question. So you have seen Sidex for certain instruments. We are using 2% glutaraldehyde. But this is not a measure for what? COVID-19. Clear? So correct answer for this question is A. By the way, see how we are going to prevent COVID-19 and important points related to this. So for COVID-19 prevention, avoid close contact with the people who are sick. Clear? Avoid touching your eyes, nose and mouth with unwashed hands, and at least we should wash hands for 20 seconds, and we should use hand sanitizer. Clear? At least 60% alcohol if soap and water are not available. This is for individuals who are not infected, and generally alcohol solutions with at least 70% of alcohol is used. So a sick person should prevent spreading the respiratory illness to others. How? Stay home, wear a face mask, cover your cough or sneeze with a tissue and discard this. Clean and disinfect frequently touched objects and surfaces, generally door handles, tables, gates, with diluted bleach or alcohol solutions with at least 70% of alcohol. So these were the questions of AIIMS surgery asked in June 2020 exam. Relatively, the surgery paper was easier as compared to previous years. So this is all about the surgery questions. Good luck.